Greeting, everyone. It's a great pleasure to come to you today to talk about what's really been a 41-year history of the Caprini Risk Score. This score has evolved as the #1 score in the world for evaluation of the surgical patient for thrombosis risk. And I'd like to share with you today why it has achieved such success. And that lies in the people that helped me put this together. And that's why I like to refer to this as the people score. Here are my disclosures. Now, we know that post-thrombotic complications, including ulcers, are a serious and lifelong disability, and they may thought to affect 7% of the patients. And this develops after a patient gets a blood clot. They get the post-thrombotic syndrome, which are chronic stasis, venous changes, and then finally ulceration. And these are some examples of that. And here, for example, is one of the most serious of those that I've found in my travels. This came from Poland, and it was a 38-year-old male who suffered a leg fracture and developed a major blood clot while in a cast. This is his leg 10 years later. The ulcer first appeared 2 years prior to this and failed to respond to treatment due in part to the poor compliance of the patient once the ulcer appeared. Now, let's not throw the patient under the bus. When patients develop things like this, they assume that it's cancer, they're going to die, and they get very depressed, and they don't want to show it to anybody or do anything. So God bless these people. Our heart goes out to them. And what we have to do is try to prevent these in the first place before they ever get to this stage. And this is the original Caprini risk document that I put together. I did the publication, and this was a later publication, but I'll get back to that, why it was Disease of the Month and when it was done. But it turns out that in 1975, I had been experimenting with a thromboelastograph, which was a way to characterize viscoelastic clotting. And it was superior to the clotting tests because it would give you much more information. And so the company that developed these pneumatic compression devices came to me and said, these devices we know moves blood out of the leg, but also we've been told that they stimulate blood coagulation. Could you use your device to help us prove that? Well, we worked on that for a number of years and did a lot of things and found out that it was a fibrinolytic component, but that component was very effervescent and so forth. But as a result of all this research, I started to use these in practice. And in 1983, with some brilliant people around me, we published a study, which was the first study in general surgery in the world, that showed the value of these compression devices to prevent blood clots much more effectively than stockings, or in the surgical stockings were widely used at the time. So when the NIH convened their first consensus conference in 1986, I was invited as a representative of pneumatic compression to present our data, which we did. And then I went to the company and I said, listen, you really need to do a big trial on this to take our little study and expand it to multiple centers and make sure it's valid. And it would be a great thing for the company. And they said, no, Dr. Caprini, it's too expensive. It would cost us $1 million. And in 1986, that was a lot of money. And also it would hurt our stocking business. So instead of that, these executives suggested creating a risk assessment. And they were James Hasty, a PhD, Tina Keibel-Ferraro, Janice Crosby, Laurie Sullivan, and Teresa Courtney. They were very, very advanced nurses that were involved in healthcare and very important in promoting these products and teaching people how to use them. So I put together a list of risk factors. And then another thing that happened in 1981 and 1983, part of the way I put these risk factors together was patterned after Maxwell Boro, who had done a series of 1,000 surgical patients and shown that the length of surgery and age are important contributors and have different powers of causing a blood clot. The most important of his conclusions, which is true to this day, is that 66% of patients with a history of VTE suffered a recurrent thrombosis postoperatively. And that was, so if they had a history before and they got another operation, then they had a high chance of getting a blood clot. And it may be a little lower than 66% in 2025 without prophylaxis, but it's still very high and has to be considered carefully. Now, The Caprini score, let's just review that. It's a thorough history and physical with 40 elements. And we've known, thanks to the work of Brownie Wheeler and Fred Anderson, that as the number of risk factors goes up, the risk of venous thrombosis increases. We also know that these risk factors are various powers. Bed rest and hormones are low power. Cancer of the esophagus or pancreas are high power. So what the score is a combination of the number of risk factors and their power. And that leads to a number which is a nonlinear increase in incidence of venous thromboembolism compared to the increase in the score. These are the results in general surgery. There's now over 460 publications as of May 1st. But what does that really mean? Well, there's a picture of Lakshman Sehgal. Lakshman Sehgal, I had the honor to work with him as a brilliant PhD. He worked in our lab for 7 years, and he was the one who developed one of the artificial bloods. And he said, Joe, you're not looking at this right. So he said, this isn't just a list of risk factors. You keep just adding those up. So in order to illustrate what Lakshman taught me, I'd like to present these two patients. Patient A is 42 years old with a BMI of 29 and birth control pills. Caprini score of 3, 3 risk factors. Second patient, 76 years of age, history of pulmonary embolus and a past cancer. 3 risk factors. Caprini score, however, as Lakshman pointed out, is 8. So although each patient has 3 risk factors, the combination of number of risk factors and their power result in a more accurate estimate of VTE risk compared to a simple list of risk factors alone. Now, I don't care if you like Caprini, you don't like Caprini, you're not going to use them, whatever specialty you're in. But if you're looking at studies which just talk about the number of risk factors, remember you're missing this very important point, that by taking the power of the risk factor and the number of risk factors, you have a much more accurate estimate of the incidence of venous thromboembolism. Now let's go back to originally what we did with this score. So after NIH in 86, then this was in 88 and 89. Juan Arcelis was a fellow of mine. I had the honor to have worked with him for 3 years, and he's now professor of surgery and chairman of the surgery department in Granada, University of Granada in Spain, and Santiago Candosia, who was a medical resident at the time and has been in private practice for many years, and ironically is my doctor. In any event, these gentlemen scored 1,000 patients at Glenbrook Hospital on preoperatively, 500 medical, 500 surgical, and they published the results. And those results clearly showed which patients would benefit from prophylaxis and which patients didn't need prophylaxis. Almost immediately, a number of countries that had national health insurance picked up on this because they could right away conserve their valuable resources to use anticoagulants where there was a real risk of thrombosis and to eliminate them where the risk was low. So my hats off for these two gentlemen who put this on the map. Now, it took a number of years before it became more accepted, and I'd like to highlight some studies here in general surgery, head and neck and surgery, and plastic surgery. And this comes from when the Chest Consensus Conference in 2012 took a look at it. And in general surgery, the incidence of venous thromboembolism with a score of 5 to 6 was 1.3%, 0.9% in head and neck surgery, and 1.3% in plastic surgery. And I'd like to highlight the Vietnamese. And actually, this is due to my dear friend Jim Caderna, who was a famous orthopedic surgeon. And when he did Operation Walk in Vietnam, he told them, he said, you ought to take a look at the Caprini score. So lo and behold, they scored 2,795,000 patients over a 2-year period at 4 Hanoi hospitals. And here again, we'll see Caprini score of 5 to 6, 1.9%. However, the punchline and the really important thing to note is that if the score goes to 9 and above, look at how the incidence goes from 1.3% to 6.5%, and dramatically in head and neck surgery from 0.9% to 18.3%. And behind this, of course, are a lot of the head and neck surgery that's done for cancer, and a lot of it's done for benign disease with low scores. So that helps to explain that. Well, in plastic surgery, 1.3% at 5 to 6, but 11.3% when the score was uh, over 8. And this was at 60 days. And again, in the Vietnamese population, it jumped to 4.5%. Now, since then, and this was what I mean about these wonderful people around the world that have helped me. Professor Kiri Lobostov from Moscow on the left, and Professor Tomas Urbanek from Krakow on the right, did a study published in the Annals of Surgery, and they looked at 68 studies enrolling 4,207,895 patients from different specialties, and they screened 4,562 references. This is the largest single study that shows the relationship between the Caprini score and types of surgery. On the top of the graph, you see the Caprini score, and then the colors indicate the relative risks. And if you look at like a mixed population, even when the score is 9 and above, 3.3%, medical patients, 2.2%. COVID jumps from 17.5 at 8 to 28 over 8. And take a look at trauma and orthopedics. It goes in different levels, 14.68 up to 10, 15.5, but then it jumps to 47% over that. So this is really important. And then on the other hand, take a look at urology and gynecology. These patients have a very low risk of venous thrombosis. So these patients don't require all the prophylaxis that the other populations require. And that's a safety factor, because if you give anticoagulants to people who are at low risk of thrombosis, they have a greater chance of bleeding than they do of helping them from their thrombosis. And I want to highlight one more group here, which is thoracic surgery, 38%. And it jumps from 10.5 up to 8. And then when the score goes to 9, look how it jumps. So it's very, very important. And in general, patients with a Caprini score of 7 to 11, the incidence of VTE tends to jump with that threshold. Now, the good news about the Caprini score is it's 40 risk factors. The bad news, it's hard to collect all of that data. But we all know that empowering patients to participate in their care is a very powerful tool. And here are some brilliant people from around the world who have put a patient-friendly risk assessment that we developed into multiple languages. And here it is. It's a very straightforward score. And there's two special features of the score, which we're going to discuss in detail. One is obstetrical complications, and the other is family history of thrombosis. And I'd like to diverge here in a second and talk about another risk assessment score, which is the British score. It's not the Caprini score, but it's a good score. You know, there's more than one good score. Especially, it's a question of, do they work and can people do it? So in the British score, they have a history of venous thromboembolism as a listing factor. And they did something else very interesting with the British score. They developed an algorithm based on the British score that you had to follow in order to get paid. And so the success rate was very high because of the economic nudge. And over a 2-year period, they estimate that they saved over 900 lives from fatal pulmonary emboli using this program. Now, the forgotten duo that we've talked about are obstetrical complications. And this means if a woman during her childbearing years has recurrent unplanned abortions, stillbirths, premature birth with toxemia, growth-restricted infant, and patients with any of these historical events may be carriers or one or more of the following abnormalities: lupus anticoagulant, anticardiolipin antibody positive, or beta-2 glycoprotein positive. Now, if all three are present, it's a strong predictor of subsequent venous thrombosis. Well, that's during the obstetrical career, but so what when patients get older? Well, first of all, the only reason that this is in the score is due to Holly Cassell. Holly Cassell was a maternal fetal, was a resident at Northwestern, and eventually went into maternal fetal medicine, and also did an outstanding career as a maternal fetal medicine specialist, emphasizing on pregnancy, and she works in San Diego, California. She told me, she said, "Joe, you better put these complications in." And I'll tell you why. Because first of all, they're important during childbearing years to predict if a woman has had risk of thrombosis. But If these patients have a history of these obstetrical complications and test positive for one or more components of the syndrome, they remain at increased risk as long as these blood defects are present. In some patients, they go away in a few weeks or months and they're transient. But in other patients, they last many years. It's very important to identify those with this history having surgery later in life because they may be carrying silently one or more of these genetic defects. And if you fail to recognize that, of course, that changes their risk assessment, and that would put them into a higher category. Not only maybe of needing prophylaxis, but maybe needing it for up to 30 days. We also know that now, more recently, a history of spontaneous abortion with negative testing, so there's still a slightly increased risk of VTE. Now let's talk about the other missing factor, the dynamic duo, and that's family history of venous thrombosis. And thanks to the Scandinavian people and their physicians, because they have a wonderful healthcare system and they keep track of all of these things. And here's a study of 183,515 individuals that were in pairs. And what they showed was that the incidence of venous thrombosis for a patient without a personal history, but with a family history, if it was first degree, it was positive, second degree, less positive, third degree, less positive, and even non-biologic relatives, people that live together, had a slightly increased chance of a venous thrombosis, and that was attributed to common lifestyles. Now, this study was out in 2013, and I've seen very little press from that. But guess what? In 2024, another study comes out from that same area, 482,000 pedigrees with offspring totaling 750,000 people. And what they showed was the pedigree could be divided into 8 different clusters based on the density of venous thromboembolism. And from these clusters, they predicted different venous thromboembolism manifestations, cardiometabolic disorders, and overall mortality of pedigree offspring. So folks, remember, all relatives, blood relatives, no matter what degree, are important to track, and even people that live together, because there is a familial vulnerability to VTE, and it's very broad. Another thing I'd like to point out is the other risk assessments, except the British, talk about thrombophilia factors as a marker of family history of thrombosis. Well, that only can pick up 30% of people, because only 30% of people who have a history of VTE will have a positive marker. So positive markers isn't the right category. It's an important category, no doubt, but you've got to know about personal family history of thrombosis in all degrees of relatives. And the data is there in now almost 1 million people. What's the missing link? Well, just as though there's a disconnect between the motorcycle and rider in this picture, there is a disconnect between evidence and its execution as it relates to VTE prevention. We have enough data. We have risk assessment tools. We know how to prevent venous thromboembolism deaths using an algorithm, but it has to be applied in a consistent and mandatory way along appropriate pathways for this decrease in fatal events to occur. And that's not being done. So I'd like to introduce you to Professor David McEnany from Boston University, who in 2008 spearheaded the goal to reduce venous thromboembolism at Boston University. And as you can see, he and his colleagues were able to get it down to less than 0.2% by 2013. The green line is the national average. How did he do it? Well, there was a mandatory algorithm. If the score was less than 5, you could do whatever you wanted in the hospital. But if the score was 5 to 8, you had to give 7 to 10 days of low molecular weight heparin shots. It didn't make any difference if the patient went home or not. 89% of people complied initially. Then, if the score was 9 and above, you had to give 30 days of low molecular weight heparin prophylaxis. 3/4 of the patients complied with that. Now, How did they do that? The Boston University is the number one safety net hospital in the New England area for the care of the indigent, in addition to being a first-class medical center for the population. And they made a deal with the drug companies and the insurance plans to make sure that every patient that needed the drug would get it regardless of their ability to pay. What a poster child for the United States. What if every hospital would do this? Amazing. But it gets better. This is the protocol, as you can see here. And this is the results over a decade, and it now goes out to 2024. 18 papers have been published using this protocol. And what happened is those skeptics, remember, 77% in the 30-day group and 89% compliance in the 7 to 10-day group. Those skeptics that didn't comply eventually started to comply because the doctors wanted to be part of the success of this very successful program. This was a beautiful nudge by example. You know, you don't get very far with yelling and screaming and whatever, browbeating, but if you have doctors examine their own results or the results of their peers, then they will very quickly come to the right conclusion. And that's a really good nudge. We also know that most of the clots occur after the patients go home from the hospital and after anticoagulants are discontinued, which reinforces the importance of the Boston program. And I'm not showing it here, but subsequently my fellow Arcellus, who published this in 2008, just republished it in 2020, the same type of results. So, you know, the more things change, the more they stay the same. Here we're looking at Virchow's original lecture hall called Virchow's Cabinet in the Hotel Charité, which is the Hospital Charité in Berlin, three blocks away from the old cabaret. And this was kept as a museum after the war. And Virchow came up with the three factors that would cause a venous thrombosis: vessel wall injury, hypercoagulability, and venous stasis. And if all three factors were present, the likelihood of a venous blood clot was high. Well, during surgery, all elements of Virchow's triad are present. First of all, the anesthesiologists have to give a muscle relaxant to intubate the patient or a regional anesthetic which paralyzes the muscles. The muscles then lose all of their tone. And Philip Coleridge-Smith from UK showed us with some beautiful duplex scan results when that muscle relaxant is given, how those veins get bigger and bigger and bigger because of the loss of muscle tone, and eventually the walls crack. In addition to that, there's hypercoagulability because this blood is puddling. It's not getting out of the leg. And metabolites from the muscles are collecting in there, and that stimulates coagulation. Also, the underlying pathology of the patient, stress, fractures, cancer, inflammatory bowel disease, and other risk factors that already elevate the level of clotting factors in that blood. So there's a lot of hypercoagulability. There's venous distension, and there's muscle, and there's vascular wall loss of integrity. So all of the factors of Virchow's triad are there, and the time of anesthesia intensifies these effects. I'd like to point out that's why we should never get rid of pneumatic compression, because it does modify those factors during the operation. Doesn't make them go away, but modifies those factors. Now, if we take a look at a 1,000,000-power micrograph from a surgical experiment by Tony Camerata, a famous vascular surgeon, you can see the defects in the lining of the endothelium. This is a 1,000,000-power micrograph, and you can see the defects in there. And in those defects is where the blood clots tend to form. And here we show a picture when the blood flow slows down, white cells change into adhesion molecules, and they continue to slow down, and finally they will come to land on the surface of the capillaries and, just like an airplane, come to a stop. And when that happens, there's an inflammatory response that occurs due to adhesion, and there is extrusion of granules. And these inflammatory granules ruin the wall of the vessel. And now you see it's got a hole in it, it has a hole in it, and it can no longer transmit oxygen and nutrients in the normal fashion. Here is an actual picture of the experiment where you can see the inflammatory cell penetrating the wall of the capillary. Very powerful experiment. Another thing is this is a bent leg, and if the leg is straightened, then 50% of the time the head of the gastrocnemius muscle will compress the popliteal vein, which is the major flow, deep vein out of the leg. All of the deep veins flow into the popliteal vein. So that's why guards are never supposed to stand at attention. And that's why when you have surgery or you have an MRI or CT scan, they put something under your knees to bend them slightly to avoid this phenomenon of popliteal entrapment. So, in summary, in surgery, minor operations may be major from the thrombosis standpoint. These procedures requiring 45 minutes of general or regional anesthesia are considered major from the thrombosis standpoint. Stasis, vascular damage, and hypercoagulability, all elements of Virchow's triad, are present during the surgery. The longer the procedure, the greater the risk. Pneumatic compression devices on the legs or feet helps minimize the effects of anesthesia and represent the standard of care during surgical procedure. Furthermore, a pillow under the knees helps avoid the straight leg position that can decrease blood flow out of the calf. So in conclusion, ladies and gentlemen, the risk assessment procedure must be followed in order to prevent venous thrombosis, including fatal PE events. Family history of thrombosis and obstetrical complications are key. The score is a dynamic instrument and must be updated during hospitalization and at discharge, regardless of the score that is used. Extended prophylaxis following discharge is important for patients with high-risk scores in any of the models, and a mandated use of evidence-based algorithms employing nudge techniques to ensure compliance are suggested. Those nudge techniques may be peer review, financial incentives, practice audits, or leading by example, as was done in Boston University. Remember, depending upon the healthcare system, country, local culture, and ability to collect data, these processes may vary. So in conclusion, I'd like to tell you something that was taught to me by a dear friend, James Schmidt, God rest his soul, who was an academic dentist in Maine. And when I told him about the risk assessment, what I was doing, he said, well, Joe, it's very simple. When you meet somebody, they're a stranger. So you have to interrogate them. So you have knowledge about them like your good friend. And once you know about them like a good friend, you would never kill a good friend. And of course, you would never treat a stranger. So, in conclusion, please go to my risk assessment, www.capriniriskScore.org, where you can see all 130 videos that I've produced. There's all 461 PubMed listings, articles if they're free or abstracts if they're not, about the Caprini score. You can ask me a question, and there are a number of other resources. So I'd like to thank you all for watching this, and I hope you all have a wonderful day.